My name is Pam Havlin. I'm from the Department of Internal Medicine, and I just wanted to welcome you all to the Breakfast Club. As you know, we meet every other month, so we'll be meeting again in January. So that's just a preview. This morning we're going to be learning about depression and how we can, as individuals, deal with depression. And we're honored to have two speakers. I'm going to introduce first Dr. Michaela Ginn from the Department of Internal Medicine. Dr. Ginn completed her medical school at Ross University and then did a residency in internal medicine and a chief resident year at UTMB. And she's since joined the faculty here. She's an assistant professor and primary care physician here in this building in internal medicine. And then Dr. Mira will introduce our second speaker.
Thank you all for being here. It's wonderful to see your faces on bright and early election day. So thank you so much. And in honor of that, on the other side, although this is not a battleground state, we have a clinical psychologist, the one, the only, the Jeff Temple. And Dr. Temple is a clinical psychologist, actually has been voted Employee of the Month for our department because of his expertise and compassion in caring for people, and also an award-winning researcher. And so we're very honored to have him in our department, and it's truly a pleasure to have him here today.
Thank you, Dr. Mayer.
So thank you very much.
Thank you.
And I'm going to focus on, how we classify people as being depressed. There's a lot of different subclasses of depression, so we decided to focus on major depression, which is what we call clinical depression. What causes it? What can we do about it? So first, major depression. To diagnose this, you need to have 2 weeks of most of the day feeling 5 out of the 9 here. Either depressed mood, hopeless, sad, loss of interest or pleasure. We often ask people, do you still like to do the things that used to make you happy? And oftentimes people say, I just can't even get the desire to get up, get out of bed and do anything. People have alterations in sleep. Either they can't sleep or they just want to sleep all the time. Changes in appetite, this can be both sides as well. They either have a loss of appetite or they find themselves eating more. And along with this goes weight changes. Either they're gaining weight or they're losing weight. What we call psychomotor retardation or agitation, where people will often say, my friends, my family are saying that I'm just talking slower or moving slower. And on the opposite spectrum of that is just agitation. Everything just seems to make me really agitated. I just don't seem to have the patience that I used to. Oftentimes people will have low energy. They're not able to concentrate. They'll start a test. They just can't complete it. Thoughts of worthlessness or guilt. Oftentimes people will think about, why did I make this decision, and this decision led to that decision. And the last and the most concerning is the recurrent thoughts of death or suicide. So to make this diagnosis of major depression, again, 2 weeks of the symptoms, and you need 5 or more. One of the symptoms needs to be that sad hopelessness feeling or the loss of interest or pleasure, and then the others can come from the list below. Now you don't have to have major depression to be depressed. There's forms of minor depression, situational depression. Where minor depression you have the thoughts of hopelessness, or you have that loss of interest, and then maybe you have some low energy as well. A lot of times life situations, moving, a death in the family, that can cause this sadness as well. A big problem that I find as an intern is talking to people saying, I really think that you're depressed. People think, no, I'm not crazy. That's just this big thing. I'm not crazy. Don't term me depressed. And it doesn't mean that you're crazy. It's a normal, natural disease that has a lot of different causes that play a role in it. As I said, it's very common. So about 15 to 25% of people will have an episode of depression in their lifetime. Women are more likely to have depression than men. It's found that there's an increased incidence in people who are divorced or separated, and it's thought to be due to a lack of interpersonal relationship. And then mild to moderate depression is even more common. So, we were just talking that, it says 20%, but I find a good majority, 40% of my patients do have some sort of depression, whether it's just situational or chronic.
Are widowed people more likely as well?
Widowed people, that loss of a person,
that loss
of a person is a big factor of stimulus for developing the symptoms of depression. So what causes it? It's a multi-factorial type disease. Thought a lot to be the dysregulation of these chemicals in our brains that control our mood. You'll hear like serotonin, norepinephrine, dopamine, and that's the basis for what we make our drugs on, to regulate those hormones. Other hormones like thyroid disease, a lot of people who have depression have like hypothyroidism or something going on with their thyroid. Cortisol has been linked as well. Genetics, people whose like mother, sister, brothers have depression are more likely to be depressed themselves. And they've done studies in twins where it's a 50% likelihood that if a twin has depression, then the other twin will have depression as well. They have linked genetics, but they can't find so far, a certain gene that causes this to occur. Like I said, life, stressors, loss of a job, loss of a spouse, a child. It's often said that a loss of a parent before the age of 11 has been shown to be a big factor. Different medical conditions, like I said, chronic medical conditions, people who are chronically ill are more likely to have depression. It's been shown that after a heart attack, people are often diagnosed with depression. Like I said, low thyroid, neurological diseases like strokes, Parkinson's disease. These are different examples. Medications that we give people, those can cause depression. Common drugs people are on, metoprolol, which is a big heart medication, blood pressure medication, that can cause depression. And lastly, like substance abuse. Oftentimes it's which caused it first. Did the substance cause the depression? Depression caused the substance abuse, but that has been linked as well. So what usually happens, it's kind of oftentimes you get depressed and it gets better, but often it can relapse and recur. First episode usually occurs before the age of 40. If it goes untreated, whether it's by drugs or by therapy, talk therapy, it usually lasts about 6 to 13 months, and treated we can usually help in about 3 months. If you have depression, one episode of depression, you're more likely to have recurrence as well. So what do we do about it? Another big problem I find is I tell someone, I think you meet these criteria for depression, but the last thing anybody wants to do is be on an antidepressant, because there's a really big stigma of antidepressant, whether it's, people's jobs, if you have to list that you're on an antidepressant, and that's a big concern for people. So psychotherapy or behavioral therapy is one option, and pharmacotherapy or drugs is another option. It's been studied that the best treatment is doing both of these things. We can usually start with talk therapy for people who are mildly depressed, just have a few of the symptoms. It doesn't really interfere with their daily lives. They're not thinking of suicide. And drugs are often recommended for the severe depression. Anyone who's thinking of suicide, can't function, can't get out of bed, that's when we would say, I don't think that therapy alone is gonna help you. So about the drugs, they are very effective. They've been available for 40 years, and they developed more drugs that are safer now. And safer meaning a big problem was that people would overdose in these medications, and the common ones that we use now, they're a lot safer in overdose. Obviously they can still cause death, but not significant side effects like arrhythmias like we used to have. There are people who don't respond. Oftentimes we have to give people a different drug after the first one to see. Some people respond to one and not another. And there is a delayed action where these drugs take about 4 to 6 weeks to really have a good effect. 3 weeks you'll start seeing some improvement. The biggest thing to improve at first will be sleep and appetite, but a lot of times people get frustrated because they're taking it for a couple weeks, they don't feel any different, and often will stop the medication. But just knowing that it does take a while. And it's really those chemicals that I talked about earlier, just balancing out those chemicals is what takes time. And another good thing about the newer drugs is they're not addictive. They don't give this immediate gratification, which is what has been linked to depression, to addiction. Drugs like methamphetamines and those sort of drugs, they are immediate. Anti-anxiety medications like Ativan, Xanax, if you've heard of those drugs, those are immediate drugs, and those can become addictive. But these drugs like Paxil, Prozac, Cymbalta, they don't work that way. So how do we choose? There hasn't been a study that shows that any of these classes of drugs are better than the other. So you have the Prozac drugs, that's one class. You have the Elavil, that's another class. And they all work the same, but the side effects are different. There's different drugs that interact with the medication, so we have to look at that. And then people respond to some. Many people have been on multiple drugs and said, these don't work at all, but this class of drugs works well for me. The group SSRIs, or serotonin receptor inhibitors, those are the most used because they don't have as many side effects. These drugs are the Prozac, Paxil, Cymbalta, Celexa. There's many in this class. So what are the major side effects? The side effects are rare. They do occur, but they're rare. Heart arrhythmias, those can happen. Elavil is a big one that can cause heart arrhythmias, but the Prozacs can cause some alterations in the heart rhythm as well. Sedation, we often use this actually to our benefit. Trazodone is one, if you guys heard of that. We often give that for sleep because it does cause sedation. A lot of times that's people's biggest problem, is they can't sleep. And so that will help with that. Seizures, there are drugs that you can't use in people who have seizures. Same going for people who, if you have an eating disorder, you should let the doctor know as well, because that will make you more likely to have seizures, and we can't use these drugs. Low blood pressure is another one. There is a class of drugs that we don't really use anymore that can cause high blood pressure, but low blood pressure is more common. And GI upset, like nausea, not wanting to eat, can be one as well. Big concern for people with sexual dysfunction and decreased interest in sex or decreased libido is the major one. Weight changes are also a concern. Most of the drugs actually cause weight loss, but there has been shown that over time you can have weight gain, and they're not sure if it's because people are feeling better, so they're eating more, and so they're gaining weight, or if it's the actual drug. And then again, toxic if we take too many of them. So if your doctor does start you on an antidepressant, what are the big things to know is, like I said, it takes a long time for those to work, and oftentimes people stop them. But if you stop them too early, or just off the bat, you've been taking them for 3 weeks and you just stop, you're more likely to have a withdrawal from these medications. And so it's very important that if you don't like the medication, we can always switch you to something else, but it's important that you let your doctor know, I don't think I want to take this anymore, and we'll be able to have you take it as a tapering dose to come off of that medication. And then just knowing that if you have nausea or any side effects, they often do go away after a couple weeks. And then one big concern as well is, well, if you start me on this antidepressant, am I going to have to take this forever? And usually not. 6 to 12 months we give a trial, and after 6 months we'll reevaluate and see how you're doing, how things are going, if you're able to function more, if the symptoms are gone, and then we'll try tapering you off of the medication. Oftentimes people who do have the recurring episodes of depression, we will recommend after 3 trials of the medication that you do stay on it for your lifetime. And when would it become more than what I would say I can handle, or you need to see a psychiatrist who specializes in depression? If the first line drugs, like these SSRIs or the Elavils don't work for you and you need more specialized drugs, that would be better to see a psychiatrist. They deal with the drugs more, so they're more aware of the side effects for these drugs. If you're having severe symptoms where you're having thoughts of suicide often, or you can't function at all, can't go to work, can't do your home things, that's when a psychiatrist will be helpful. If you have any other psychiatric conditions, if you're hearing voices, those kind of things probably are beyond an internist. If there's any substance abuse that goes along with it, drug abuse, alcohol abuse, and just if your counselor or psychologist thinks that it probably would be a good time to go over there.
All right.
So we're gonna.
So while I'm setting up this video, I do want to say a couple things. The first one is Dr. Ginn mentioned that divorced and separated is related to depression. One of the interesting things, which isn't good for us men in the audience, is that initially it seems that women get more depressed with the divorce and separation, but over time women are actually returned to baseline levels and men become more depressed, so as they realize what they're missing. So take some comfort in that. And the other thing that I think is interesting is Dr. Ginn mentioned that one of the side effects of pharmacotherapy, one of the big ones, is decreased libido. Well, when my patients mention that, when I'm referring them to an internist or a psychiatrist, and they're depressed, well, you don't want to get out of bed, you're probably not wanting to have sex right now, so let's give these medications a try. And yes, that is a side effect, but you're not having sex right now. You don't have much libido as it is, because that too is a side effect of depression. All right, so as I hook this up, let me play this video real quick.
Did you know that more and more Americans are stressed, anxious, and depressed? And studies have shown that these stresses can lead directly to poor health. It can become a vicious cycle, a cycle that's not easy to treat. But now, there's a cure. Ask your doctor about Fixitol, the pill you take once that instantly takes care of all these concerns. Fixitol. Fixitol is not available in North America, South America, Asia, Australia, Africa, Europe, Antarctica, or the North Pole.
While it is true that mental and emotional health can affect your physical health, there's no quick fix for many of the concerns brought on by life stresses. But you can talk to your physician about a treatment that's proven to be effective for depression and stress. When you ask your physician to recommend a licensed psychologist, you're taking a first step toward a healthier mind and body. Through treatment, psychologists arm patients with new understandings and lifelong problem-solving skills. For example, helping you make healthy choices, especially when you're feeling depressed, anxious, or stressed. And though some conditions do require medication, for moderate depression, psychotherapy is just as effective as medication, without the risk of side effects and lower instances of relapse. It is time to talk to your physician, but not about the latest miracle cure. It's time to ask for a recommendation for a licensed psychologist.
Often we hear physicians or other people say, you need to go talk to a therapist, you need to get some talk therapy, you need to get a psychologist. Well, not all therapies are created equal, and we do have some very good evidence-based therapy out here. So this is where we have really randomized controlled designs, which is what you want in research and studies, where you actually have groups, one group getting this type of therapy, one group getting another type of therapy, and one group getting no therapy. And we have shown through these randomized controlled studies that certain types of therapies are very effective for certain conditions, like panic disorder, for instance. There's people that are walking out in the real world with panic attacks, and they get treated by physicians, or they don't get treated at all. They don't leave the house. We're very good at treating that. Give us a few sessions, and we can make some really good improvements on a majority of patients. So, in here, one of the things that is often mentioned is for anxiety and mild to moderate depression, psychotherapy should be the first line of treatment. We are very good at what we do in treating these mild to moderate depression and anxiety. We have really good treatments available for those, often better than pharmacotherapy. And then I am a fan of medication, so I'll talk about that here in a second. And the other thing is longer lasting results. One of the things Dr. Ginn mentioned is that we could have a trial for 6 months on these medications, and that's absolutely true. The problem is if you do nothing to target those symptoms that are causing the depression and you just take the medications, well, then you're just treating the symptoms, just treating the serotonin levels. When you get off the medication, if you've done nothing to sort of correct the reason you're depressed, then after you take the medication, likely that depression will return, or you'll begin to not feel as the mood that you had prior to depression. You'll require more medication. So it's very important to get psychotherapy in addition to the medication. So why mud-colored glasses? I don't know if any of y'all were wondering that in terms of the talk of our, title of our talk, but one of the things I tell every single patient that comes in is, when you're depressed, it's like you're wearing, and I use this word here, mud-colored glasses, right? And when you wear mud-colored glasses, how does the world look? Right? How does your past look? Muddy, or that word. How does your future look? How do your relationships look? How does everything look? Well, everything looks muddy when you wear these mud-colored glasses. I almost slipped there. So when you wear these mud-colored glasses and something that throughout the day something happens, well, you pay attention to that stuff that confirms the muddiness of your life, and you discount some of the positives, and we'll get to that in a second. But when you wear these mud-colored glasses, everything looks negative, right? And you pay attention to the negative stuff, and you discount all the positive stuff. And so what happens is, as you go throughout your life, all that negative stuff comes in, and then it's like, well, of course I'm depressed. Look at all this negative stuff happening to me. Again, though, you're filtering everything with these mud-colored glasses. So the job of a therapist is to wipe some of that mud off your glasses, right? So that's the job. It's not to put on rose-colored glasses. That's not the job of a therapist or a psychologist. That's not the job. We're not trying to say that the world is perfect and you need to wear these rose-colored glasses. We're not saying that. We're just saying look at the world for what it is, the positive and the negative. So the ABC model of depression. This is kind of how I think about depression. So I'm going to need a volunteer for this. I don't know if you're a good one or a bad one. Dr. Jernalov has volunteered. So Dr. Jernalov, you're driving down the street and someone cuts you off and it seems pretty deliberate, like they did it on purpose. What's your immediate reaction to that person?
It depends if I think they're a Republican or Democrat.
Well, speaking to that, I'm glad we had this today because half the audience will be depressed tonight. I'm not saying which one, just half of it, based on the polarization.
Yeah, initially you're probably upset because you think you're going to be endangered.
Absolutely. So you're upset. You're angry, right? When someone cuts you off and it seems deliberate, that's your immediate reaction, right? So someone cuts you off, causes you to feel upset, angry, right? Okay. Now say somehow you found out that this person, Dr. Jernalov, was rushing to the hospital to be with their wife who's about to give birth to their first child. What's your reaction to that? Somehow you found that out.
All right, you'd be much more understanding of
so more understanding, more compassionate, whatever, right? So how could this same event cause two very different reactions? One, you're angry, and the other, you're understanding. Well, what I would argue as a cognitive therapist is that the event never causes you to feel a certain way, ever. No matter what happens, someone dies, that does not cause you to feel sad. What causes you to feel sad, or angry, or understanding, is your belief about this. So when you believe that person cut you off to be a jerk, that causes you to be angry. When you believe that person cut you off because they're rushing to the hospital, that causes you to be understanding. So it's your belief that's important. And this can be a rational belief, it can be an irrational belief, it could be a positive belief, negative belief, or a neutral belief. And how you believe on that, if it's a positive belief, well then that relates to a positive feeling. If it's a negative belief, then that relates to a negative feeling. And it's important to say here is that by negative, I don't mean bad or anything like that. I mean negative in the sense that it affects you in a negative way. So these are very normal beliefs, but it affects you in a negative way. Neutral belief, you have a neutral reaction, neutral feeling, right? So what does this mean? Well, this is really, 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 really good news. Why is it good news? Why is it good news that our thoughts cause our feelings?
Because we have a way to control those.
Exactly.
Control our beliefs.
Yeah. So if we can know that thoughts cause our feelings, well, that's really, really good news because that means that we're not just passive beings in this world that bad things happen and we feel bad. We have control over it, and we can control the way that we think about stuff. Very hard. It's not easy, and that's why it takes therapy. But it's very difficult, but it can be done, and that's why it's good news. So an example here, another one. Mary is walking down the street, and her friend Sarah walks right on by. Mary thinks, I guess Sarah doesn't like me. She gets sad and ignores Sarah. And this happens over and over again. I mean, if with my patients is, my husband came home and I was dressed, very sexy, and he just went and turned on the football game. And therefore, my husband doesn't find me sexy. And what is that? How does that make you feel? Pretty muddy, right? Right? So you feel bad about that. Now, let's think this B here. Mary thinks, I guess Sarah doesn't like me. She's wearing mud-colored glasses right there, right? Couldn't there be another explanation? So B is often accepted as the truth, especially when we're wearing mud-colored glasses. That's accepted as truth. Well, Mary doesn't like me. Well, of course you're going to feel sad, and in the future you're probably going to ignore her because you're mad at her and you think she doesn't like you and you think you've done something wrong. So of course. Now, let's use this as a different way. What's an alternative for why Sarah walked right on by?
Sarah was preoccupied with something else and didn't see Mary.
That-
May have been very pleased if she had noticed Mary.
Absolutely, and that you're pointing it out right there. So Mary is walking down the street and her friend Sarah walks right on by. Mary thinks Sarah seems distracted. And the result of that is Mary calls out, Sarah apologizes for missing her, and they go for coffee. Obviously, this is very simplistic, but you can see the difference. You know, if we are wearing mud-colored glasses, we accept the second one as truth, and we go throughout our day and it negatively affects us. If, however, we want to, we wear normal colored glasses, maybe Sarah, maybe she doesn't like Mary. That's entirely possible. Maybe Sarah hates Mary. But we don't know that unless we do this, right? And then if we do this and Sarah still ignores her, well, then we can worry about the alternative. But let's try that. You know, let's just not assume that someone hates us because they ignored us. Let's not assume that someone cut us off because they're jerks. Does that make sense? All right. So the way we think about the event is important in predicting how we feel. It's very important, too, because oftentimes we can't change the event. You know, unfortunately, we can't change whether or not someone dies. We can't change whether or not Obama or Romney wins the election tonight, you know? So, thinking with mud-colored glasses. So what I mean by this, again, this is going back to when we think with mud-colored glasses, we think the worst, we think the negative, everything that happens confirms our negativity. And I confirm, I do mean confirms our negativity. So say I have this core belief that for whatever reason, I think that I'm a failure, or I'll make a fool of myself, nothing works out for me, I'm worthless. Have you, by a show of hands, not you yourself, will not incriminate anyone here, but from friends that you have heard them say one of these four things, right? By show of hands? Every single person, right? And it's this, when you wear these mud-colored glasses, you take this as truth. I'm a failure. Things happen throughout the day. You know, say your boss yells at you. Well, there's confirmation that I'm a failure, right? You're late to pick up your kids. There's more confirmation that I'm a failure. Your husband doesn't want to have sex with you at night. Well, that's proof that, you know, I'm ugly and no one likes me. Right? All these things happen, and it confirms this negativity. But the problem with this is that we discount the positives. Well, that doesn't count because anyone could do that. You know, and one of the things is, well, you have 3 healthy kids that are doing well in school. Yeah, but it's despite me, not because of me. Well, my husband's really good, or I don't know how they turned out so good, or something like that. You know, they discount the fact that all these positive things are happening. So with these core beliefs, what I mean by that is something maybe happened when you were little, or maybe something just, you know, stuck with you that you have this core belief. This negative self-perception, and then things happen throughout the day that confirm it. And then it confirms this, and this gets, you know, kind of wrapped up in that. And when you're wearing those mud-colored glasses, it's hard to get out of that. All right, so now I'm going to change gears just a second. I'm going to return to the thought processes, but one thing that a cognitive behavioral therapist is what I am. So I focus on the cognitions, which are the thoughts, and the behaviors. So let me ask you a question real quick. Have you guys ever had a dirty house and someone was coming over and you needed to clean it, but you really didn't feel like cleaning the house? Right? Everyone here has had that, right? Every day. Yeah, every day. But someone was coming over and so you had to clean the house, right? Well then, has anyone experienced this where you start cleaning the house and you meant to just clean it a little bit, but for whatever reason you got kind of into it and you cleaned it even more? Well, that's an example of that, you know, people think that if you're motivated, you're more likely to do stuff. Well, it's actually the other way around too. If you start something, it's going to increase your motivation to do that thing. So it's bidirectional, this motivation and behavior. And how that relates to this is, well, when we're feeling really depressed, when we're feeling, you know, down about ourselves, what do? Well, we lay in bed and we do nothing. It's characterized by inactivity and withdrawal, as Dr. Ginn stated in her presentation. You know, depressed people spend a lot of time in unrewarding behaviors. What do I mean by unrewarding behaviors? Well, watching TV, brooding, complaining, and I don't mean that bad, lying in bed, just not doing a whole lot of stuff. Just laying in bed. And it's understandable. They have low energy. They're wearing these mud-colored glasses. I don't blame them. I would want to be doing the same thing, right? But when we do that, we don't experience this reward that we get from doing behaviors. So one of the things that we do as a cognitive behavioral therapist is we really force people to do stuff. It's called behavioral activation. And basically it's, I know you don't want to go out and walk the dog, but we're going to prescribe you. Since I'm a psychologist, I can't write prescriptions, but I can write behavioral prescriptions, and I will prescribe them, walk the dog twice a day. Get out of the house, stop laying down. You're not going to feel like it. You're going to feel like just laying in bed, doing nothing and watching TV, and that's understandable. That is a symptom of depression. We're going to counter that symptom by I'm going to force you to. You don't have a choice in this matter. I'm making you go walk your dog. Or for postpartum depression, I will prescribe date night with the husband. You have to get a babysitter to watch this kid, and you and your husband are going out on Friday night. Every Friday night you're going out. And you'll see that that works. And it's behavioral activation. It's forcing them to do stuff, forcing them to clean the house like we talked about. And what do you do when you start cleaning the house? Well, then you get into it. So when they start going out on date night or when they start walking the dog, well, then they start to get, okay, this is kind of fun. I like this. I want to do it. So then they look forward to it. In the prescription, you don't have to do that anymore. They used to love to cook. Well, I don't cook anymore because I'm depressed. And I don't feel like getting up. And I just don't want to do it. But I really liked cooking before, but I have no interest now. Well, you're going to cook 3 nights a week. That's the prescription. I know you're not going to want to. You're just going to want to lay in bed, and that's okay. I understand why. But for these 3 nights, or 2 nights, whatever you think you can do, we're going to do that. And they start cooking, and they get into it, and they get interested in it. And then you don't have to prescribe it anymore. And so it feeds off of each other, right? So then they start doing something that they used to like, and then they get rewarded for that behavior, rewarded by positive mood. And so it plays off of itself. And then we wipe a little bit of that mud off the glasses. And that's the point of this. So here's the other thing that I do, and every patient that comes to see me gets one of these thought records. And I'm sorry that it's not bigger, but I'll talk about it here. So this thought record is what I do at the very first session is I just give them these first few. I say, let's write down when you get especially sad or especially anxious or something like that, or you have some negative thoughts, some automatic thoughts. And those automatic thoughts I didn't talk about earlier. So when we have automatic thoughts and something bad happens, or something neutral happens, like Sarah walking by us and not talking to us, maybe my thought is what Dr. Forbes said is, well, that's, she's just distracted, whatever. But someone who's wearing mud-colored glasses is, their automatic thought is, well, there's proof that she doesn't like me. Why does everyone hate me? And so those automatic thoughts are what we're trying to find in these thought records. So that's what we're trying to discover in these thought records. And it's not easy because these thoughts are automatic and you don't pay attention to them. You just have that thought instantly. So we have to really pay attention to these automatic thoughts. So what happened when you felt this way? What were some of the thoughts that went through your mind, and how much did you believe it? 1 to 100. Well, let's look. And then emotion. What emotions did you feel at the time? How intense were they? 1 to 100. So that's all I focus on for between the first and the second session, is just finding these thoughts. Not trying to correct them yet, just finding them. There's a gentleman and I took this from a book, and I have another book suggestion for you all before we leave. But there's a man, that feels like he's getting too old and he feels kind of worthless. He has that core belief of worthless, and something negative happens, or he can't play with his grandchildren. Well, there's confirmation that I'm worthless, right? And so we look at these. So here, situation was the guy was out of breath when he played in the park with his granddaughter. His automatic thoughts were, I'm too old to play with her. I can't do what I used to do. I can't be her caregiver. I have nothing to offer my family anymore. I am a burden to my family. I am no good to my family. And you might think, well, why would he think that? Well, if you wear mud-colored glasses, of course you're going to think that. And those are the thoughts that go through your head. And those are, how's that going to make you feel if you have those thoughts? Muddy, right? Or horrible. So his emotions and mood are going to feel, he's going to feel defeated, sad, disappointed, hopeless, worthless, all those. And you can see that he rated these as hopeless as an 80, 1 to 100 scale, and worthlessness as a 90. Well, of course he's going to feel worthless and hopeless if he has those types of thoughts. Well, as a cognitive behavioral therapist, I want to examine whether or not there's evidence to support those thoughts. So I treat my patients as fellow scientists. And I say, let's see. Maybe you are. And I do say this to my patients. Maybe you are worthless and hopeless. Maybe you are. Maybe you should be saddened. Maybe you should be defeated. Maybe you should be. But let's examine the evidence. Let's just look at it. You know, I haven't been wrong yet. I hope I'm not ever right about that. But, you know, maybe you are this way, but let's examine the evidence. Let's see if there's reason for you to feel this defeated and hopeless. Let's get out there and let's see. So let's examine the evidence. Evidence to support the thought. What are some evidence to support his thought, by the way? His thought that he's too old to play with her, that he can't do what he used to do, that he can't be her caregiver. So my family has to look in on me more often than they used to. There's one evidence that, you know, that supports that thought. Sure, that's one side of it. Absolutely. I'm glad you brought that up. Evidence that doesn't support that thought. Well, I can still babysit the kids, the grandkids. I contribute to my family in new ways, such as offering advice and support. I still live independently. I'm able to do many things physically, though I do have more limitations than I used to. So there's some other ways so we have the evidence. Yes, you know, my family does have to look in on me a little more than usual. Yes, I do get out of breath a little bit more. But, you know, there are these other positive things. And then we look at an alternative thought. And this is because of my COPD, which is a respiratory problem, and because I'm getting older, I have more physical limitations than I used to. And I do need my family's help from time to time, but I'm able to offer them more valuable things and contribute to my grandkids' lives. And then how much do you believe this? Well, an 80 out of 100. Well, how's your mood now that you've changed your thought to that more realistic, more accurate, more evidence-based thought? Well, my mood now, my hopelessness, I still feel a little hopeless, but it's down to a 10. My worthlessness, I still feel a little worthless, but it's down to a 5. Negligible amount, right? So that's kind of the point of this cognitive behavioral therapy, is really focusing in on changing those beliefs. It goes back to that ABC model, changing those beliefs to change the way we feel, and then also focusing on those behaviors to change the way we feel. And that's, I guess I should have put this slide up before I went into that, but basically the summed up with cognitive behavioral therapy and depression is negative beliefs cause negative feelings. Positive beliefs cause positive feelings. Beliefs can be changed, that's the good news, and behaviors maintain these negative feelings because it's going to be hard to change your beliefs if you just stay in bed all day. And I know that that's easier said than done. When you're depressed, it's hard to get out of bed. Behaviors can be altered, and this is hard work, but it can be done. All right, so the take-home message, and this brings in everything that Dr. Ginn and I said, is that psychotherapy is effective and often the first line of treatment for anxiety and mild to moderate depression. However, that being said, pharmacotherapy is an excellent adjunct to psychotherapy, especially when you need some of these principles to take hold. Like if that person really just doesn't want to get out of bed, or that person just really has thick mud on their glasses, then it's good to give them some little help with SSRI or some antidepressant to get them bring them up to where they can use some of these more talk therapy resources, these cognitive behavioral approaches. Or if after you use therapy it's not getting better or it gets worse, then absolutely pharmacotherapy is a great adjunct. And then the pharmacotherapy is effective and is the first line of treatment for severe depression. And really, cognitive behavioral therapy can work for severe depression, but it's a heck of a lot easier if we can get that mood lifted and that behavior a little more active before we start the therapy process. So psychotherapy is I do say that psychotherapy is a necessary adjunct to pharmacotherapy for long-lasting improvements. So if we want to address just the symptoms, pharmacotherapy is the way to go. But if we want to have more long-lasting improvements, pharmacotherapy coupled with psychotherapy. And let's see. The last thing a psychiatrist wants to hear when treating someone with a multiple personality disorder, gee, doc, I feel like a brand new person. All right. Thank you all very, very much. So questions?
I work in prison at Carroll Young Unit as a mental health case manager, And we talk about like analyzing your situation to see if it's really as bad as you think it is.
Yeah.
Some of them it really is.
Yeah. No, that's a great point. That's a very, very good point. And you bring up a good point, is that cognitive behavioral therapy may not be effective for every patient all the time. That there's certain conditions that it's effective for. You don't want to use cognitive behavioral therapy with some forms of schizophrenia, like paranoid personality disorder or something like that, or if the situation suggests otherwise. Now, I would argue that you probably could do cognitive behavioral therapy in a prison, depending on the patient and the person and their scenario. I mean, if they were getting out in a few months or even a few years. But I could argue that you could adjust it a little bit for that population. But yes, I agree. There's certain settings and populations that it's probably not the best for.
Well, and because I have some that will send us sick calls and they say, I'm depressed, but you know, we're limited in what we can do. We really can't do a therapist full time with them or anything. But I was just wondering, from my position, is there any suggestions on what I might do to improve their overall mood?
Yeah, so are most of your clients, are they getting out soon, or is it the in for life, or is it?
Some are hospice, so
I
guess they're in for life.
Well, there's different types of therapy. So and that's an excellent point. There's something called acceptance and commitment therapy. Right. ACT. I don't know if you've heard of that, where it's really kind of Stephen Hayes is the father of that, Hayes, and so it's acceptance and commitment therapy. And it's the same thing like with pain disorders that aren't going to go away, right, or someone in hospice or someone like that has these lifelong things, whether it's the rest of their life means 60 years or 6 months, is more of kind of accepting your situation, committing to it. And I'm not explaining it that well, but moving on from it. So I'm not an ACT therapist, but if in someone in that situation, I'd refer them to someone like that, or I would suggest use that. There's also something called motivational interviewing, which is if these folks are in prison, my guess is that there's a behavior that they want to change. And with motivational interviewing, that the whole focus is on changing the way we behave, changing the way we do things. And that could be done in a 3-minute session with the physician or a 50-minute session with the therapist. But it's basically just a scene where the patient, where they are right now. So if they have a big drinking problem and they don't want to stop drinking and they're in prison, you can say, well, how does drinking related to what your goals are? Well, my goals are to be with my family and to contribute to society. Well, how does drinking fit into that? And talk about that, and then get them to talk about the change, get them to talk about it, and that's the focus of motivational interviewing.
Okay, thank you.
Thank you. So the book that is really good for the population is this book called Mind Over Mood. There's several available. This is a really good one. I often suggest my patients pick this up. It's called Mind Over Mood. I have copies of the cover, so you don't have to do that.
I think that's a very good point, particularly for women who are very scared of hormone therapy and who come in with menopausal symptoms, of which mood lability, that sort of the swings, is very significant for them. And so that's one of the treatments that is available that doesn't involve actual hormones if they have a contraindication to it, or are just anxious about the idea of hormones because they've heard, and you've got so much time to explain to them the studies related to hormones and their safety versus their efficacy, the risks and the benefits. And for some women, that's a very good option to start off with.
Yeah, and I'll make 2 points about that. The hormone stuff is out of my area. I will say, on many levels, right? Yes, I agree. One thing is with therapists and psychologists is we should make sure that we rule out some of these physical causes like hypothyroidism or hormonal changes, that sort of thing. I will also say, though, that a lot of people that experience psychological problems manifest themselves on a physical level. So just because someone has physical complaints as opposed to kind of the typical depression symptoms doesn't mean that psychotherapy, that cognitive behavior therapy won't help. In fact, as you can attest to, I imagine a lot of your patients that come in, you can't find anything physically wrong with them, but yet they're complaining of aches or pains or something, but there's nothing physically wrong with them. I'm guessing a substantial number of your patients. And so on those cases, it's just that how the depression manifests itself. And certain cultures manifest itself differently, or it might manifest itself differently in men. Maybe there's more substance use, whereas in women, maybe there's more missed days at work because I'm in bed.
Yeah, we see a lot of that with like chronic pain syndromes and the diagnosis term fibromyalgia. We're not really sure what causes that. A lot of the depression overlaps with that fibromyalgia. We often treat it with an antidepressant, which has been found to be good with this chronic pain. They just have pain everywhere. You can't find anything really necessarily wrong in that the lab tests are normal and the x-rays are normal and things like that, but they do suffer from this chronic pain that's often very debilitating. Often this.
And it is painful, and I think when we talk about when we talk to them about how it might be depression and how antidepressants might help with this, it's oftentimes very hard for them to swallow because they think we're saying, oh, you're not in pain, you're just depressed. But that's not the case. You're in pain. We just think that it's a manifestation of that's how you become depressed. Whereas other people get really sad and cry. Maybe you feel this fibromyalgic pain or a combination of the two.
Well, we want to thank both of you for presenting. That was really wonderful. Cognizant of everybody's time.